have one question for you. Where do you see, use of PCI for like LCX or RCA disease and a mid-cap for LED? Does this have a better role in treating a diabetic patient?
Well, this is obviously a standard strategy for a hybrid revascularization, but I've always maintained that science and society cannot be separated. And we have to talk of what is relevant to us in this country. And I strongly believe that adding to the cost of myocardial revascularization by doing hybrid strategies may serve the purpose of science, but will not serve the society. And therefore, I'm not a votary for hybrid revascularization.
Dr. Yadav, I have a question. What set of patient of CAD will be requiring revascularization? You will submit for PCI. You are a surgeon. Sorry, I'm asking you the wrong question. But
no, that's a very right question.
Refer to you for CABG, amongst which you will select that this patient has to go for PCI, not for CABG.
Well, I hope I have behaved like a non-surgical hawk in this lecture. I have tried to be balanced in my approach, and I strongly maintain that we are overdoing with my interventions. That I have no qualm, openly speaking, we are overdoing PCI, we are overdoing CABG. We need to optimize these patients for medical management much more. Having said that, your question, one, in acute coronary syndromes, no question, no debate, CABG is nowhere. For simple logistic reasons, PCI scores over CABG. All patients which do not involve proximal LAD, I would say PCI has a very good role to play. And even if you look at the guidelines, today it is said there is no difference between PCI and CABG if you can give equivalent complete revascularization. And I still feel that in PCI we give marginally less complete revascularization than with CABG. When you compare apple to apple, there is no difference between PCI and CABG. So wherever the cardiologist feels if the surgeon can give 4 grafts and he can open those 4 arteries, I'm for PCI.
Dr. Yadav, what I feel, if it is a diffuse lesion, not a discrete lesion, if it is a diffuse lesion, I think PCI is totally obsolete. So CABG takes over 100%, number one. Number two, the overall mortality, overall recurrence of stent stenosis and all these things. So CABG scores over PCI. What's your comment on this, on these 2 points?
Well, sir, this is a basic nature. You know, CABG addresses a lesion, while bypass surgery addresses the segment. So we know that the proximal segments of the coronary arteries are more prone to atherosclerosis. So CABG is always done to the mid-LAD. So the entire proximal segment is bypassed. So that's the nature of the two. But then let's also grant that PCI is much, much lesser invasive procedure than CABG. So I don't think it can be discounted. I think this debate of PCI CABG is more for the for showmanship. I think they are truly complementary procedures. And even if we do a CABG 6 years later, 1 graft gets blocked, it's these cardiologists who come to our rescue and open that.
Dr. Bhitis has comment about diffuse lesion versus discrete lesion, whether it's a proximal or a mid. So what you will do as an interventional cardiologist, you will go for angioplasty or you will hand over the patient to the surgeon. Dr. Shah's comment.
So I think of course, as an interventional cardiologist, the bias would be towards PCI, but at the same time, I think the decision making with the consent of the patient is most important. Okay. Please discuss with him what is your preference. Give him a 5% restenosis rate. And if he says that I don't want any restenosis, I only want a one-time procedure, please go to the surgeon.
Thank you.
In a proximal mid-LAD. But if he says that, okay. I do not want an invasive, such a big invasive procedure, I am ready to take a 5% risk of intervention, then I would say, then I would give him a precision PCI with all the gadgets and give him the best results.
Okay.
not otherwise. If you are ready for that, then otherwise I don't want to do a haphazard procedure, just doing one balloon, one stent, getting out and saying my job is done. No. Give a perfect result, because then it has to match
Dr.
to the
Yadava.
surgeon's lima to LED.
Dr. V.T. Shah, which patient of CAD we will not submit to PCI?
I showed you the list. See, I showed you the list also, and Dr. Yadav also showed that the only difference was he said that less than 22 he would still. I think that is old data and old recommendation, but nevertheless, as I said, that we have to discuss. See, there are gray areas available, and there we have to discuss with the patient. Obvious, as we said, as I showed you in my slide, ACS and poor targets and COPD patients and all that, all those kind of patients, or redo post CABG patients having MIs now or occlusions now, we open it up. So all those patients, yes, we will do. Many other patients where there is triple vessel, calcified vessels, and the cost involvement may be more, the restenosis rate would be more, then you have to discuss with the patient. So if the patient says, no, I am ready to take a one-time risk of PCI, if there is restenosis, I'll go to CABG, but one time you give me this chance, okay, fine, I'll give you that chance with the best possible technology I have as on today. So I think most important is all give the plus and minuses of both the procedures. We will give of ours, the surgeons will give theirs pluses and minuses, and let the patient decide. That will be in the gray zone.
Dr. Shah, still I am unable to understand. If it is a long segment lesion, diffuse lesion, you will not hand over the case to surgeon, or still you will do the angioplasty?
No, I'll tell you.
Long segment diffuse lesion.
I will tell you the first angiography which I showed of the diffuse disease, tandem lesions right from top to bottom of that LED. I did the spot stenting of the proximal portion and left the rest of the portion. So I covered the most important, the diagonal and the septal, which I wanted, which will give him good contraction. The rest distal LED, which was diffusely diseased, I didn't do anything. And I left for optimum medical management. Okay, this was in consultation with the surgeon. He said that the tail of the LED is already diffusely diseased, where the blood will flow.
Dr. O.P. Yadava's comment, please.
Now, two things, Dr. Shah. One, I would have appreciated if you had not labeled that it's an outdated data, an outdated recommendation.
Sorry.
No, please listen to me carefully. I have never in my slides ever, last 30 years, ever presented outdated data. That is the latest European guidelines. Sorry, you are outdated. Please tell me any recommendation, otherwise withdraw your statement.
No,
Number two.
I am saying in presence of imaging, they have not mentioned at all anything about that.
So when you say
that is why was my bias towards PCI. That was my bias.
This is the current guidelines. You said these are outdated guidelines. These are current guidelines.
Sorry to use that word outdated.
Yes.
I appreciate that.
So that's the difference between
surgeon and
cardiologist. We are very precise. Number two, when we were talking,
tell me, Dr.
Number two, when we talk of, we will discuss with the patient. Then the patient has to be discussed in a heart team where everyone is present, not in your own office, that the surgeon will crack open the chest and jack open the sternum. Or do you want me to place a daintily a stent? This is the way you put forward. So please, where is that heart team concept where a surgeon is made to sit with a cardiologist, a patient sits with his general physician? Then that argument is valid, but that's not happening. That's very sad. And that's what I'm saying. We are overdoing. I'm admitting I am overdoing CABG. Please, even you are doing angioplasty. Today, we need medical therapy, ischemia trial, courage trial, mass trial. How much evidence do we want that we need to step back on all this? Yes. We are doing more harm to the patient than good to the patient. Sorry, but that's what my...
Thank you, Dr. Yadava. I think thank you, Chairperson, since we are running sort of more than 1.5 hours.
Thank you,
Dr. Yadava. Thank you, Dr. V.T. Shah. Thank you, Dr. Raman Sethi.
And Dr. P.C. Manoria. A big applause. Big applause for the
so-
conducting
so-
such a beautiful session.
Yeah.
That
Thank
also
you. Thank you, Dr. Asamurthy.